Welcome back, Dr. Steciuk.
Thank you for re-inviting me.
Pleasure. When I was watching the episode last time, I realized we delved straight into the subject and I forgot to ask you a question that I ask most of my guests. Some are quite shocked by the way I ask the question. So I always ask them, what is their why? Why did they choose that profession? So why did you become a doctor?
Okay, I might shock a few people, but nevertheless, I will go. You know, it's actually a question that our teachers asked us in the second year. You know that in France, you have to do like a championship the first year. So they will select only like 140 over 3,500 candidates. And then if you manage to achieve that championship, then you go into the second year. So my professors asked me, and actually I answered them because I like to have a challenge every day. And it's very rare that people answer by, I want to help people. If you want to help people or be close to patients or be close to people, do nursing school. Don't do medicine, because we don't spend much time with patients. We are there to solve problems. So you have a medical problem, we analyze it, we try to solve it, and then we move on to the next patient. But nursing, they will spend time with the patient. They will go through the pain with the patient. That's not what we do. So, and I told them, if I do 2 times the same thing in 2 days in a row, I'll get bored. So I need a new challenge every day. So that's why I love my job.
You have a new challenge every day?
Every day.
Really?
Yeah, every day. And patients are always new. When I wake up in the morning, I have absolutely no clue
what the day has in store for you.
So I can have, like recently, I have a very rare syndrome, what we call Caroli syndrome. That was exciting. And sometimes you find out a new disease that's amazing.
Do you find it frustrating sometimes when you aren't able to solve the problem?
Not frustrating. I think I become nuts. Sometimes even at night, I wake up and think, oh, I should think about that diagnose. So I write down some of the diagnose, or in my mind I write it down so to be sure that I think about it the next day. So yeah. But what I would say it's frustrating is when you know the diagnosis, you know the treatment, but the patient can't afford it. That's highly frustrating when you can't give the best possible care.
And I asked that for lawyers as well, because I wouldn't say we're in similar professions at all, but particularly lawyers who do criminal law and family law, sometimes it can get it's difficult to remain emotionally detached.
It's impossible.
So how do you sleep well at night?
Well, to be very, very honest and very open, sometimes I cry. And many people don't realize that, because we don't have a very physical job. But at night, sometimes when you go back home, you are mentally and emotionally drained. So yeah, there are days I do cry. So even though I'm a guy and come on, I have emotions like everyone else, and that's completely normal. And I think it's important actually to deal with your emotions. And I would even suggest that every doctor needs like a psychological follow-up, because unless you are completely detached and don't care about what you do, then yes, it's very easy. But I'm not like that. So, and I think it's important sometimes to have people you can chat with. And that's why some doctors have this very dark humor, because that's one of our ways to just to decompensate or put the pressure down and then make jokes about it. Just before that, I was like having a conference about mental health. And someone asked me a question, and I answered with a joke. And I said, oh, by the way, I'm Damien, and I do jokes when I'm uncomfortable. so yeah, sometimes you need to have something you can let out. And so it's not easy. There are easier days than others. But I think, I love my job. So I think every day is a new day. And yeah, if you love what you do, you try to be the most invested in it as possible.
So in July, I went to see some dear friends of mine who live in Manchester, and one of them is a surgeon, and he specializes in neurology, cancer particularly. And we were drinking champagne, as you know. So the next day he had a 6-hour operation, and he was talking about it. And I said, how do you get yourself in that state? And he said, what's worse is that the particular operation that he was doing, I think his figure was 50%. 50% of people will die within 1 year. And that's hard. to as
Horrible.
a medical professional to
Yeah.
to know that, because you're still. And I said, how do you do it? He said, well, there's 50% chance she might not die.
Exactly. And I remember once I asked one of my teachers when we were in the ambulance and we were on an accident and a kid died, and I was really down. And I asked my teacher, how do you cope with it? And he said, the day it doesn't do you anything, stop medicine. Then you become a robot or a machine. Just stop it, because then you will be useless. We need people like that have the courage to go and try. Even if there's only 10% chance of saving the patient, that's something. Well, thank goodness there are like surgeons like him here that they try at least.
Yeah, and it went very well. I asked him the next day, how did it go? He said it went really well. So fingers crossed for the lady. So let's start with our subjects. We've got 5 today, but I think we were only covered 2 probably. So I wanted to focus on some of the things I hear all the time, diseases, or as I like to call them, dis-ease among Mauritians. High blood pressure, very common. And there's something that you said last time that intrigued me, but I didn't have the chance to do a follow-up question, is that you said that some people who have no stress have high blood pressure and vice versa. And I always, for some reason, I don't know why, I always associated high blood pressure with stress. So maybe you could demystify, first of all, what is high blood pressure and what are the kind of the main causes of
Okay, so well, high blood pressure could be actually a subject on its own for. I might come back again. We might even have like to do a series of videos.
I think so.
But high blood pressure, we know that there are few organs in our body that actually set the good pressure. So we have the kidneys that have a very strong mechanism to make your blood pressure raise. Why? Because when we were still fighting against animals with like spears or swords or whatever, and we didn't have guns where we could shoot an animal at 200 meters, sometimes you would get hurt and bleed. And if you bleed, your blood pressure needs to raise up quickly so you can stop the bleeding and you can stop from bleeding out. So our mechanisms genetically are very strong to raise the blood pressure. And it's called, one of the mechanisms is the renin, angiotensin and aldosterone system, and that one is in the kidney. You have another system that is in the carotids, arteries, and you have a third one in your brain, and there are a few others. But those systems, with age or with certain circumstances, they will dysfunction or malfunction and create high blood pressure. So it can be linked to a disease, it can be linked to age, it can be linked to stress, but it doesn't have to be linked to stress or to age. Even kids can have high blood pressure. And there are even some studies showing that amongst obese children in America, 10% were supposedly high blood pressure. And the blood pressure doesn't depend, well, it depends of your height when you're a kid. So there's a chart when you take, have you ever been with kids at the doctor's? Obviously, yes. And it's very rare that we take blood pressure with kids. Yeah. Very rare. So when I read that study, I tried to see if I think that the child is overweight or obese. I tried to take the blood pressure because sometimes it's high. And maybe if the blood pressure is at like 11.8, which would be normal for an adult, but it's very high for a kid, depending on their height. So there are charts that you can find on the internet. What's the good blood pressure for a kid? So high blood pressure in children also exists.
Wow.
It's obviously less common in adults or in high age, but it does exist. So it can be linked to lifestyle. If you eat too much salt, should be careful with that one. We do know that if you have high blood pressure, then your system is not functioning or malfunctioning. If you eat a lot of salt, it will become higher. But if you don't have any malfunction and your system is working perfectly fine, even if you eat a lot of salt, you won't have high blood pressure. But again, it's easier to stop salt when you are not used to eat a lot than if you're eating a lot than to reduce the salt.
Okay. So lifestyle, it could be stress. Did you say genes as well?
Genes, yes. Well, I didn't say, but definitely your genes are in
So
fact.
if it runs in my family, does that mean I'm going to get it as well or not necessarily?
That means that you have a higher probability of having high blood pressure. But again, it depends when the parent had their high blood pressure, and how they had their blood pressure. If, let's imagine, you had a father that was highly stressed, having a very stressful lifestyle, and he's developing high blood pressure, it doesn't mean it's genetically. It just means his lifestyle caused high blood pressure. So it won't affect you. But if he was, let's say, 40, having a normal lifestyle, and his blood pressure started to raise because of one of his systems that was malfunctioning, then yeah, you're at higher risk of developing high blood pressure.
Okay. So what are the two, because normally you see two figures.
Yes.
What do they mean?
Oh, let's do the easy version. We have two blood pressures, so we only say 11/8. Normally doctors should say 110/80 because it's in millimeters of mercury. It's a pressure. It's the higher figure is the systolic blood pressure, and the other number is the diastolic blood pressure. That means when you take this arm cuff, it squeezes your arm, and it will squeeze the arm up until your blood doesn't go through anymore. So it will stop the blood flow, and when the blood flow is stopped, then it will release. And the first heartbeat that you will feel or hear, that is the highest blood pressure that needs to be exerted on the artery to let blood through. That will be like 140, 120, and so on. And then it will release the pressure, and then at a certain point you won't hear the pulse anymore or feel the pulse anymore, and that's the lowest blood pressure to create turbulences in the tube, and that's the diastolic blood pressure. So blood pressure always is taken on your arm. Why? Because it's at level with your heart.
I see.
Another question: is it the same blood pressure left and right?
I feel that is a trick question.
Because yes, the blood pressure is exactly the same in your left arm and in your right arm. If there's a difference between the two arms, maybe because of like lung embolism, that can change. So many patients of mine, when I take their blood pressure on their right arm, say, "Oh, doctor, shouldn't you do it on the left arm?" No, it's the same. But it has to be at heart level. Okay. That's why when you do the blood pressure on your wrist and you have your arm lower than your heart, then it's probably a wrong reading. Or if you put your arm like in an angle, you again change the blood pressure. So the best blood pressure is the one you take at the arm, well, for common use.
And is this something that can be, and again, I think it might be a myth, or something I've told myself, is it something that can be completely reversed by good lifestyle, exercise, food, nutrition?
Well, that's a very good question. If the blood pressure is linked to, let's say, obesity, let's say too much stress, or a very unhealthy lifestyle, yes, if you reverse everything that is causing the disease, it might. But unfortunately, very often it is not caused by those factors. So it is very often not reversible, and it is a chronic disease.
Really? Okay. And what are the dangers of?
Well, they are unfortunately very clear. That's what we call the MACE, or the major adverse cardiovascular events, which will be stroke, heart failure, heart infarct, and obviously death of heart failure or development of end-stage heart failure. And it can even cause kidney dysfunction or kidney failure.
Oh, wow. Okay.
So it's not a good disease to have.
Yes.
But we do know that stroke is nearly 100% linked to high systolic blood pressure. And we do know that for heart failure, the systolic and diastolic blood pressure are very important. So if you go and see your doctor and says, "Oh, you're at 12/10, you're young," that's high blood pressure. Because
the number...
For young people, diastolic blood pressure will raise before the systolic blood pressure. For elderly people, when the arteries are more calcified, more rigid, we are less flexible than when we were 20 or when we were 10. So even our arteries are less flexible, and then the systolic blood pressure will raise.
Are there any symptoms of it? So, for those who never go to the doctor, because, as you probably know, most people go to the doctor when there's something wrong with them, as opposed to when they're perfectly healthy. So how can they tell can they tell or no?
The vast majority, there is absolutely no symptom.
Wow.
And that's why we call it the silent killer, because if they knew, they would treat it and we would get rid of strokes, obviously, or there would be far less strokes. But many, many young people don't know they have high blood pressure because there's no symptom. One of the symptoms you might have is what we call headaches, or sometimes people feel like a heart pulse in the head or in the brain. They even tell us, oh, I feel that my heart is pumping in my head. And it's very easy to take the blood pressure. So I think everywhere there are handcuffs or cuffs to check the blood pressure.
And you can have one at home. You can buy one. And
it's not very, very expensive. And even if you don't, you can go at the pharmacist and ask him to take your blood pressure. And they will do it. Some ask you for 10 rupees, I think. Why not?
It's worth it.
But check it, because it's not painful, it's not invasive, and it's easy to check.
Yeah, and are the kind of the meds that are available on the market generally quite effective at lowering?
It's the first cause of death worldwide, what we call the cardiovascular diseases, and high blood pressure is the first cardiovascular disease, or the most common cardiovascular disease. So obviously it's a market that all the labs want to have a part in, so they are very motivated to have very good drugs and very potent drugs on that, because millions and millions of people that need it. So yeah, we do have very efficient drugs. Actually, we have many efficient drugs to bring the pressure down, but we don't have many to bring the pressure up. I have some of my lady patients that have low blood pressure. Sometimes I struggle to bring it up.
What is that fascinates me as well. So what causes low blood pressure?
There could be also a dysregulation of the pressure. So when we all have like an internal thermometer, we also have an internal barometer that tells us what is our homeostasis or our equilibrium state. Our equilibrium state, like for example, for temperature is at 36.5 or 37. For pH, it's at 7.42, and we also have a blood pressure. And that is a variable. It's not the same for everyone. So if there's a dysregulation, there might be like a low blood pressure since very young, but some women suffer from varicose veins, and when the veins are too dilated, the blood stays in the legs and doesn't come up, so the blood pressure drops. And we have obviously anemia that can cause low blood pressure, especially if you have very heavy menstruations and you lose a lot of blood. Then obviously your blood pressure will drop.
And then some of the symptoms of that are when they feel faint or...
Exactly.
Yeah, okay.
Yeah. Or when you stand up quickly and you have like this vertigo, it could be linked to low blood pressure or a drop of the blood pressure.
Okay, so it's not as good news as I thought it would be. I thought you were going to say exercise solves everything, but
unfortunately not with blood pressure. But definitely healthy lifestyle
helps. Yeah,
definitely helps, and even helps for the complication of high blood pressure. So it can actually help the prevention of some sort of strokes and some sort of heart attacks. So yeah, definitely.
You mentioned high blood pressure in relation to obesity, and I don't think we spoke enough about that last time because it was in a very specific context, and I think that's one of the things that I don't think it's a phenomenon that's particular to Mauritius. I think worldwide we have become, well, it's too easy now to have limitless number of calories, I think. So I wanted to delve a little bit into that, and the first question I had was, why do we become fat? So the reason I asked that is that what I wouldn't want you to say is that it's calories in, calories out, because I think, maybe I'm wrong, I think it's too simplistic. Is it just a question of calories in, surplus calories, or is it more nuanced than that?
No, it's more nuanced than that, because there's also the factor of how's your metabolism rate. There are some people that can eat up or ingest 3,000 calories per day, but that won't make them especially fat. Their metabolism is burning a lot of calories, and some people eat far less, and there are even people that eat very little and gain fat because their metabolism rate is very, very low. So we have to be cautious about just simplifying too much, saying, well, eat 1,000 calories, lose 1,200 calories, you will lose 200 calories a day. That's not that easy, because you could have a thyroid problem and become more fat. So there is a whole lot of diseases that will induce obesity, and there are so many obesities. Like we can have abdominal obesity, we can have people having a lot of subcutaneous fat, and some people have a lot of fat in their organs. Those are more at risk of organ failure than people just having subcutaneous fat. So it's not that easy, BMI, not BMI. I even don't really care about BMI because actually my coach, he's also an MMA fighter, and he's 96 kgs, but he's definitely not fat. But his BMI is obese-ish, but he's just very muscular. And muscle is twice as heavy than fat. And if you are like 96 kgs and you are very muscular, you have to eat at least 3,000 calories a day to maintain that muscle level. But it also depends what kind of calorie you eat. Because it's not the same eating a donut that is, let's say, 300 calories than 300 calories of fruits or vegetables. So it's completely different. So we shouldn't be simplistic, say, eat less, you will lose weight. No, eat healthy, have a healthy lifestyle, and if you don't lose weight, go and check if your metabolism is right, or go and check if your system is functioning properly, your thyroid and all the rest.
So you mentioned 2 different types of fat, and I think that's quite important because I think, as you said, there's the subcutaneous fat, and then the other one, I think you're referring to the visceral fat. So why is visceral fat dangerous?
Because that's the one that will cause more atherosclerotic diseases. So that's the one that will cause your arteries to be more inflamed. And that's something we could talk about also about cholesterol. You know, very often people think that, but the cholesterol is good and is important for the arteries. Yes, it is. But we do know that if someone dies of a heart attack and you do the autopsy and you cut the coronary artery in the middle, you will see that it's full of cholesterol. And it's not because that there are ashes that there are fires, it's because that there are fires that there are ashes. So the cholesterol came into the artery because there was an inflammation of the artery. So the artery was inflamed, the cholesterol tried to repair it, but while repairing it, it blocked it. So we did something maybe stupid, but we thought, let's remove the cholesterol. But I don't think that's the best way of treating the cardiovascular disease. That's one of the tools we have now, which is very efficient, but I don't think it's the best one. Ideally would be to remove the inflammation of the arteries, and that would be to reduce visceral fat and do more exercise, sleep better, stress less, and those are the factors that could induce an inflammation of your arteries. So yeah, the subcutaneous fat is less dangerous-ish than visceral fat, but it's still an excess of fat can lead to oxidative stress, or let's say some substances that will inflame your system.
And I think one of the things that can be quite dangerous as well is that I read a stat somewhere that said that 20%, or maybe it's less, I can't remember, of people who look healthy actually have dangerous levels of fat. But because they're skinny, I like to call that skinny fat, because they're skinny, they're not aware. And in a way, it's more dangerous than the person who's obviously obese and doesn't know. So for those type of people, how can do they have to do a special scan? How do they know the level of fat that they're?
Well, it's not that easy because with bariatric surgery, many of our obese patients are motivated to do such a surgery just to lose like 40 kgs in a very short period of time. But we have to select the right patient for the right treatment. And we need to do an MRI to calculate the visceral fat. If you have someone that is highly obese but has no fat in their organs, it's useless to do bariatric surgery. But there is a high visceral fat and not that much, let's say, subcutaneous fat. Those are very good candidates for bariatric surgery. So it has to be selected by your physician or by the surgeon or by your doctor that will go through that procedure. So it's not that easy. So mainly the MRI is the one we use to calculate visceral fat. Now they try to do, those scales, this
yes,
impedance.
They're not very reliable though, are they?
Not really.
Yeah.
They give a good indication, but they are not that reliable. So we try to find out more, let's say, markers, metabolic markers like apolipoprotein B, homocysteine, CRP, ultrasensitive CRP. So those are other markers, or even the HOMA test, the insulin resistant test, that can show us, is that person having a metabolic disorder or not? And you do know that now we are even going to change the name of that disease called NASH, non-alcoholic steatohepatitis. We'll call it MASH. It will be the metabolic associated steatohepatitis, because we do know that, well, it's a bit too reductive to say it's non-alcoholic or it's alcoholic. It's metabolically induced. So
is that the fatty liver?
The fatty liver,
yeah,
exactly.
okay.
So that we call NAFLD, now we call it MAFLD, well, metabolic associated fatty liver disease. So we'll put more emphasis on the metabolism. And because the metabolic disease is a cardiovascular risk factor on its own. Just imagine you have like a blood pressure is at 100, 35/87, and you have, let's say, your sugar level is at 5.9, you have your cholesterol LDL is at, let's say, 2.7. So you don't have one particular disease, but all those, let's say, markers are slightly elevated, and those put together are a risk factor, cardiovascular risk factor.
It's quite well established, the lifestyle driven causes of obesity, but as you said, there are also non-lifestyle driven, so metabolic dysfunction and hormonal issues. So what are the most common forms of non-lifestyle driven causes of obesity?
Well, the most common one is hyperthyroidism, because it's very common, but it's easy to correct. When you have hyperthyroidism and you just need to do a blood test, the treatment is well tolerated, and we just give you the thyroid hormone, so it's reversible. There's even like Cushing syndromes. We have like a high grade of obesity, and obviously all those rare diseases like Prader-Willi and all these diseases. But the most common one is hypothyroidism.
And that's purely genetic?
Well, that's a touchy subject. Since 1986.
Okay. No?
Chernobyl.
Really?
Yeah, it's very, very common. I remember when, I was only 4 at the time, so I don't remember. But on the French TV, they said, well, the toxic cloud is just stopped at the border of France. Come on, they even measured in Norway, which is far further, some cesium, whatever. Obviously, it went through France, it went over all Europe. And now with Fukushima, we might have, again, loads of thyroid disorders and thyroid cancers.
Do you think that's passed on to generations?
Well, the problem is the people being born 86, they are turning 30, how much, 37 now? Yeah. So they are at the right age to develop.
I see.
They have to check their thyroid correctly. Well, Mauritius is quite far though, but people that lived in Europe between 80 and 90 or were there when Chernobyl exploded, because it exploded only a few days after that the authorities said that there is a problem. It's actually one of the Scandinavian countries that says our detectors detected something weird on the cesium.
It's crazy.
So all Europe was polluted with that. And with the pollution, the air pollution we have now, it's madness. We'll face more and more metabolic disorders, more and more thyroid problem, more and more endocrine perturbances. So, yeah, I don't think our kids will live very healthily very long. I don't want to crush the day, but...
Oh no, I was gonna, I had this whole map in my mind as to, I'm reading this book at the moment that basically says that, so comparing what he calls medicine 2.0 is about increasing lifespan, and he's saying that medicine 3.0 should increase health span, because we become very good at treating, but not necessarily when you look at the people in their 70s and 80s, etc., the quality of life that they have is actually quite poor.
Yeah, exactly. So we should definitely focus on staying healthy longer, not staying alive longer. I love the field of diabetology, but for a very long time we were very glucocentric. So we would only focus on sugar levels. And we saw that people being aggressively treated would have less complications, but would still die earlier. So now we are shifting the paradigm on more organ-centered treatment. So we try to protect the end organ. When you have diabetes, obviously your end organs will be heart, brain, and kidney. So you have to protect those of hypoglycemia or hypoglycemia. And we should focus more on being healthy for a longer period of time, not just treating diseases.
I also read this book recently about, I think it might have a genetic factor as well, but there are some pockets of villages in the world, I think in Sicily and Japan, where they live like 122, and some of them drink wine every day. But it's one of the things that it also says, it's not medical at all, is that they move all day, and moving all day doesn't mean doing an hour exercise a day. It means moving all day, and also community, always being surrounded by people, because loneliness kills, as we know. So, since we've got into old age, I want to move on to one topic that I think a lot of people find scary, which I think in most cases, correct me if I'm wrong, is a age-related disease, which is cancer. I remember, again, when I was talking to my friend in July, he said something that shocked me, actually. He said to me, all things being equal, if there was nothing else wrong with us, we would all die of cancer one day. It's just that something else usually kills us first.
I completely agree. Yeah, he was right. You know, if we remove cancer from humanity, let's imagine, how many years would we gain of lifespan?
If we remove cancer, now, in this 5?
Only 2. When Alexander Fleming discovered penicillin, how many years did we win?
I don't know.
15. So I think the most amazing discovery in medicine was penicillin, actually. Actually, I have a very old book at my place from 1927. It's what we call a Larousse Médical.
Okay.
It's like a dictionary, and I was looking up antibiotic.
Okay. It didn't exist?
It didn't exist.
Wow.
So it's only after that the antibiotics were discovered. So obviously we have a genetic code. And this code has 3 billion, let's say, codes. Okay. And it has to be, imagine you have to rewrite a book. And that book has 3 billion letters. Okay. How many mistakes do you think you will do after one copy? Obviously you will do one. But we have a system that is so amazing, it can replicate completely at nearly 100% our genetic code for each cell division. But sometimes it will make an error. And if there's an error that is repeated and repeated again, this is what we call a mutation. And one of the cells may mutate and become what we call crazy and start to divide itself and lose its function. And when you have a cell that is dividing very quickly and losing its function, it becomes what we call a tumor. Okay? Why do we call it cancer? Because it looks like a cancer. Because when it develops, the tumor, it will have 2 expansions that will develop and looks like, you know, these small animals.
Yeah, the little crabs, yeah.
Exactly,
yeah.
It's a cancer. So when that tumor will develop, at a certain stage, it will breach through a blood vessel, and those cells that are crazy and dividing very quickly and losing their function will spread into the body everywhere. And if it diffuses in the blood and it's developing everywhere, the first organ that it will attack, it's our lymph nodes, because that's the organ that will reabsorb that particular cell. And the second organ is when it's spread everywhere, so it's not placed where it should be placed, it will be meta-placed, it will be a metastasis. So that's how we call a cancer or metastatic cancer. It's when the tumor has spread all these cells everywhere in the body. And that's how
So then it's out of control, basically.
Then it's basically out of control. And it's very rare to cure metastatic cancers, what we call the end-stage cancers. So it's very complicated. And you know, oncology, you were saying about your friend that has 50% chance of saving one patient. You know, sometimes I receive a phone call telling me that one of my patients died. It's quite hard, but oncologists, they have this phone call 3 times daily. They see patients dying every flipping day. It's I don't know how they manage to do it, but you should invite one of my colleague oncologists and you'll ask him the question. But it's so hard as a medical specialty. But we do know that the treatments are advancing, and what oncologists do quite well, they talk to each other. So very often you have what we call an international protocol that will, if you are here in Mauritius or in Malawi or in New York, you will have the same protocol for treating a very particular cancer, if it's available, obviously. But they should do all the same thing, wherever you are. And the treatments are developing. We see new trends of treatment, even in oncology. I'm not an oncologist, so it's not my specialty, but we do know that science is advancing. But now the question is, why are cells starting to mutate? There is obviously this replica that can change, that's caused with age, and there are some toxics that we ingest every day that can induce some cancerous development, like tobacco, alcohol, stress, and many what we call this hypertransformed food that will induce an inflammation, and chronic inflammation can lead to a cell that will actually mutate and become cancerous.
You know, obviously you've identified some of the risk factors, but from my reading, and it's quite depressing reading actually, it seemed to me that I wouldn't say the majority, but a lot of cases is just pure dumb bad luck. Is that true, do you think?
I hope there are only adults listening, but sometimes I tell my patient, life's a bitch.
It's true.
Sometimes you never smoked a cigarette of your life and you will develop lung cancer. And it's just unfair. Why do you have kids leukemia? Why do you have kids brain cancers? Because some kids have brain cancer, just it's like that. It's not fair. I know. It's frustrating, but that's life. That makes also life so beautiful, because it's so unpredictable. So we should enjoy life every day, because it's an everyday gift. And I like that YouTube video that said, if I give you $10 million now, would you be happy? Obviously, yes. But if I tell you I give you $10 million now, but tomorrow you die, would you still be happy? Would you accept them?
Of course not.
Of course not. So your life is more worth than $10 million. So enjoy your life. And I don't say enjoy your life by drinking a lot of alcohol and smoking a lot. No, but enjoy your life healthily, because it's a gift. And obviously you can do many things that will induce cancer, but there's some things that are inevitable, and that you will develop eventually a cancer, and it's like that. I don't know. And that's the beauty of medicine, because there's a whole lot of stuff we don't know. And that's
yet
amazing.
to be discovered,
Yes.
I guess. I hope so.
Just imagine, in 1927, they didn't have antibiotics. So they didn't know how to treat like pneumonia. Now, even yesterday I saw a kid with pneumonia. Come on, I just gave antibiotics, it's fine. And it's much better now. So imagine in 10 years.
Do you think because, yes, I agree with you regarding antibiotics, although that's a topic of its own that we'll have to discuss another day because of the massive overuse of antibiotics. I think it's crazy, but anyway, that's a separate subject. But I feel that the statistic you gave earlier was quite telling, because you said we added 15 years when, communicable diseases were kind of dealt with. But for non-communicable diseases, including cancer, I feel that, I wouldn't say you were losing the battle, but when you look at some of the treatments available, and I'm not a specialist, but like chemo, it's a harsh treatment. And my question was going to be, are we making enough progress, do you think, in that field? Because there's money going in it. There's a lot of research going in cancer treatment. And, I appreciate you're not an expert, but I just feel that it's, as you said, if it's a solid tumor, they'll take it out. And if it hasn't spread, generally the survival rate is pretty good. But if it has spread, then there's limited options. There's
very limited options. But when you don't have the choice, you take whatever option you have.
Sure.
Well, what does chemotherapy do? To break down something very complicated to something very easy.
Destroys everything, basically.
Well, it actually destroys every cell that is dividing quickly. So that's why you lose your hair, you lose your eyebrows, you lose even some part of your skin, even your mucosa in your mouth or in the vagina, you will lose it, because those cells divide quickly. Which other cell divides quickly? Cancerous cells. So we're destroying everything. And we do know chemotherapy is a poison. But that's a necessary poison, because if we don't give you the chemotherapy, you might end up dying in a few months. If we give you the chemotherapy, it might earn you another year. I know it's depressing. I know it's not a good answer, but it's the only one we have now. And now with research going forward with immunotherapy and all those subjects, we see that we have a better outcome. But I don't think it's the only way. Get me correctly. I'm not saying that we should avoid chemotherapy, no. But I think that when you have found something and it seemed promising, we have this natural way of dealing with things where we're going to dig deeper in that area, even though we're in the wrong hole. we will dig deeper. So I think we should find new ways of treating cancer besides just chemotherapy. But imagine you have a patient that has, let's say, X cancer, and you can give him something you know might work. Or you give him something else that never has shown that it could work. What would you choose? Definitely would go on the chemotherapy because it has been proven that it might work. But, and you see, that's why we should change again our paradigm in medicine, not because we were wrong or we were trying to be wrong all this time. No, because we can look for something else. And there are even parallel medicine that seem promising. So why not go and dig deeper? You know, I always compare medicine with the 5 fingers of the hand. The allopathic medicine that I studied in Paris, I compare it to the little finger because that's the one with the shortest view. You have a disease, I have a treatment. Take the treatment, get out. There is a parallel medicine like osteopathy, all these treatments that are not like allopathic medicine but are definitely a good medicine. You need an alliance with your patient. That's why I compare it to that finger. There's this what we call traditional medicine, like Chinese medicine, Ayurveda, acupuncture. That I compare it to the middle finger because it's the longest one. It's the one that is the oldest. They have been there for, let's say, thousands of years. We've been there since yesterday. So for thousands of years they treat patients. So I compare it to that one. Then there's this functional medicine. Says, well, your pancreatic system or your glucagon thing is not working, and it's pointing the finger at the function is not working. And that's the medicine I try to practice, which I compare it to the thumb, which will connect all these fingers, what we call integrative medicine. I don't mind my patient going and see Ayurveda practitioners. I don't mind my patient going and see an osteopath. I don't mind seeing the function of that's not working. And I don't mind medicine, because sometimes it's important. But we should have this integrative approach where we could actually accept different views. Even though we're not saying, well, if you go and take that treatment, stop chemo. No. Chemo has its place, and it is very important that we dig again on the research on chemotherapy. But let's not be so narrow-minded and saying there's only chemotherapy. There might be something else. And that's why it's good that they developed even immunotherapy, where we actually put chemotherapy on your immune system, and your immune system will carry that chemotherapy to the cancer cell, and then you kill the cancer cell.
Yeah.
Like radiotherapy is again another treatment for cancer, but very often we imagine radiotherapy like being something very precise. Just imagine like a huge cannon of laser that will just burn your cells. So that's radiotherapy.
So it's a whole area as opposed to just
burn it.
Bury it to the ground. Yeah.
But again, I think prevention would be best. But you see, we are.
But we can't prevent that, can we? I mean, assuming I don't drink, I don't smoke, I don't,
Some are unpreventable, I do agree. But again, we have our genetic code that has what we call a limited date. So there is your system is, since your birth, prepared to end after certain years. How many years? I don't know, for you. For other people, I don't know. For me, I don't know. But we already have what we call an expiry date since our birth. And we won't go beyond that. If you have no cancer, no disease, if you don't smoke, don't drink, and you're perfectly healthy, perfectly happy, you have your expiry date. And that one, you should not go beyond it, and we shouldn't even try to go beyond it because it's already done. So we should, it's more a philosophical view. We should more enjoy what we already have. You know, one philosopher said that happiness is to desire what you already possess. I do agree. Then just trying to avoid any disease, because there are some that you can't avoid, and it's on your path. It's there. Now how you deal with it, that's another story. But cancer is a very, very complicated subject because it is unfair. Definitely is the unfairest disease ever.
Yeah. And it's not one disease, it's a collection of, multiple hundreds, I don't know how many different
there
kinds
are many.
there are. But
there are many. We even do like a very bad joke in medicine. Again, when we're not comfortable, we make jokes. So we always say there's nothing that is 100% in medicine. But the death rate of pancreatic cancer
Although some people have been cured though, haven't they? No?
Never read about it.
Really?
No long-term cure, no. Pancreatic cancer is catastrophic. No, it's a very complicated disease, but I'm sure with development, even with AI and all these instruments that we have, that we increase our knowledge, we will quickly find more and more solutions to cancer. And we just need to be open-minded that it might not be chemotherapy, it might be something else.
Or chemo in conjunction with
Exactly.
something else. Because you mentioned immunotherapy, but I also read about this other, it's not a cure, but it's just I would say a theory, that cancer cells love sugar.
Yeah,
they love glucose.
That's how they divide.
Yeah. So there have been some anecdotal studies of people who were on some form of treatment, maybe chemo, maybe not, I can't recall, but at the same time went on a ketogenic diet at the same time. And the other people who were on the clinical trial, they all died, and that person didn't. So I don't know whether there might be some promise there in terms of the role that glucose has to play in and you know, try to find some treatment that way. I don't know.
It's very, very interesting, and we do know that sugar has a huge impact on cancerous cells. We shouldn't give people hope that is not sustainable, but we shouldn't say, well, no, it's just sugar, we have to stick to the mainstream way of thinking. I think it's interesting. Let's go and look deeper into that stuff and see after a while if it really is true or not. We don't know for sure now. It might be. Let's stay open and let's hope. But we can't tell the patient it will work because we don't know. For now, we don't know yet.
So it's not related to cancer, but I guess it's similar in the sense that I sometimes view cancer as it's basically the body trying to destroy itself. Maybe that's quite a harsh way of picturing it, but it might be the case also for other autoimmune diseases, because it's basically your body attacking itself, right?
Yeah, I remember once I had a young child that developed an autoimmune disease. And he said, oh, so if I understand correctly, that means I'm allergic to myself. And I was, well, that's the best definition ever. Even my teachers in medicine, they couldn't explain that well. So I was like, yeah, exactly. So you're actually producing antibodies against yourself. So your body attacks yourself. Why? No clue. Why is it happening? We don't know. But even like type 1 diabetes, why do you produce like antibodies against your pancreas? Why in Graves' disease do you produce antibodies against your thyroid? We don't know. But what we try now more and more is give antibodies, what we call monoclonal antibodies, to treat those diseases. So we trigger, or we just go and destroy that particular antibody that you produce against your body, which is very promising, but not working obviously in 100% of the cases. But it's weird, but many autoimmune diseases, they start after, let's say, an emotional shock. So there must be a link. There has to be a link between emotional states and our autoimmunity. So where is that link? How is that link? I don't know, but there has to be. So very often we try to see the patient being body, mind and soul. But we're one. When you have a patient that has an autoimmune disease, don't just treat his antibody. Treat also his mind and treat also his how he's emotionally.
Yeah.
Because going through what we call a chronic disease is very painful and it's very hard. So we should always try to accompany the patient even psychologically, because they will deal with it every day of their life. So it's important. So there has to be a link. And even if you're emotionally in a better state, I'm sure that the outcome of your autoimmune disease will be better.
What are the most common ones that you spoke about type 1 diabetes, but are there other common ones that you see here in Mauritius, like arthritis, rheumatoid arthritis is one of them, right? Or not necessarily?
What we call polyarthritis rheumatoid. Sorry, I studied in French. Rheumatoid polyarthritis is one. There is SPA, spondylarthrite ankylosante, is ankylosing spondylarthritis. There is Hashimoto's disease, which is a thyroid disease. There is Graves' disease, another thyroid disease. There is Gougerot-Sjögren. It's a Swedish guy.
Okay.
Because
He discovered it.
SJÖGREN is what we call the dry syndrome.
Right.
You don't produce any tears.
Oh gosh.
And one of my patients had that. I have a few here in Mauritius because, but they're all in the same family. And she said, what I miss most is crying.
Oh. So she used to cry, and then when she developed
no more
the disease,
tears.
oh
So
my
she has a
gosh.
dry mouth, dry eyes, and it impacts also the kidney function. You also have in the autoimmune diseases, you have type 1 diabetes, which is very common, unfortunately.
Particularly for children, right? Although it can be developed later.
It can be
on as
developed
well.
with adults, and sometimes it's much more uncommon to have type 1 diabetes as an adult, but you can still have it. But there are many. There is like sclerodermia, there is Schurz-Strauss, there is... if you
have to look up those different names. I haven't.
It's fascinating, but we have so many antibodies that we can develop against ourselves. It's scary, actually. If you read medical books and you see all the disease that can occur, it's kind of scary.
And I guess that's what makes your job so challenging as well.
Exactly. and I remember my teacher in cardiology, his professor Jean-Louis Michel. He was like this rugby man. He was scary, but we just loved him.
Okay.
We always used to call him Dad, because whenever he would come to the ward, we were just like reassured. Okay, Dad is here. Everything's going to be all right. And
is he still around?
Unfortunately not. I think he passed away. He always told me, you will only find what you're looking for, and you only look for what you know. If you don't know the disease, you won't look for that disease, so you won't find that disease. So know as many diseases as possible, so you will look for those diseases, and then you will find the many diseases. And that was always fascinating. So I was always reading about these rare diseases like Fabry's disease and Cowley's disease. That.
Do you ever come across patients here that were really?
I had a Prader-Willi. For the doctors listening, it's quite rare.
So what are the symptoms? What is that?
Well, there's a genetic disorder
okay.
with high obese children.
I see.
And even had like one of my patients, she came to me and she said, doctor, I have Cowley's disease. You know what Cowley's disease is?
No, I have heard of it, but I don't know how the symptoms present.
And just a few months before, I had another patient who had that disease, because it's one person over 10 million. So that is highly rare. And so she said, do you know? And I was, as a matter of fact, yes, I do know, because I already have a patient like that. It's a very rare disease of the liver. She got transplanted of the liver and now she's fine. But she was, again, that's so unfair, because she's 38, 39, and has a liver disease that needs to be transplanted. But she's just fine now, so.
I remember that my mum always tells me the story of my granddad, who she says never drank in his life, or he didn't drink, and he died of what we now know to be MALF, as you said. So, but I think at the time people associated it with it only happens to people who die, and we still don't know how he, whether it's genetic. I don't know.
Even thin people can have fatty liver disease. You don't especially have to be obese to develop. That's why we call it metabolic associated fatty liver disease, because it's your metabolism. And if you have a metabolism that is not working well, or putting too much, let's say, fatty acids in your liver, you will develop fatty liver disease. And then you will develop steatohepatitis, and that steatohepatitis can develop cirrhosis, and cirrhosis can develop to liver cancer.
Okay. I'm not going to ask about the other topic because this is too depressing. So we'll leave that for the next episode. But before, let's try to end on a hopeful note for the audience. So AI. So if we could talk a little bit about that, because you mentioned a couple of exciting things that you've come across. So we talked about HOTS the other day. So maybe let's leave our audience on a hopeful note. What are the things that you are most excited about today about AI and what it can bring to medicine?
Well, on a doctor's point of view, AI will help us a lot in diagnosing. So there will be probably apps where you can actually have like a skin disease. You just take your phone, you do a picture of your skin lesion, and you already have the diagnosis. Wow. So you come and see your dermatologist, say, voila, I have psoriatic disease, whatever, and he will confirm or infirm if it's the right disease or not. But then you will already come with an idea. So that's very interesting. And even for doctors, we will use that AI. There is another AI, for example, in ophthalmology. It's you just put your head in front of a camera, you take a picture, and the camera will tell you if you have diabetic retinopathy. So that's very good for screening. We actually have that digital retinal camera in Mauritius.
Oh, it exists already? Okay.
It already exists
in clinics or in
it's
hospitals?
in what we call an NGO that treats diabetic patients called APSA. And there it is.
Wow.
So we can screen, but only for retinopathy. It won't replace the ophthalmologist, obviously not, but it will screen. Let's talk a bit about the future, because that's going to be very exciting. Surgeons will have glasses where they will see with augmented reality what they are cutting. So you will have your glasses, you will watch at the thing and will say that's the knee. And you will tell you where to cut to open.
Wow.
When you open the skin, they will say that's what we call the tibialis nerve. And then so on. So don't cut that. You see, like in a video game.
Wow.
So you already have the thing.
So the room for error is massively reduced.
Exactly.
And the precision.
Robotic surgery is going to be amazing. Now we even can operate on fetus. So imagine you are in the womb of your mom, and we can operate inside. So that's
amazing.
It is amazing. So I think the future of medicine is highly exciting. Obviously, I don't have the most joyful work in the world. That's why I hope I don't depress your community too much. But the future is very exciting. Now, what we're going to even develop is what we call intelligent insulins. It means that you will inject your insulin and will only activate if your sugar level raises.
How is that possible?
I'm so excited. I just came back from a conference and we spoke about it. We spoke about the once weekly insulins. So there's these new developments, and AI will help a lot. AI will even, there are these insulin pumps that calculate your sugar level. So when your sugar level raises, the processor will tell the pump to increase the insulin flow. So it will bring back your sugar level. And if your sugar level drops, it will stop injecting.
So the pump is inside of you, or
the pump is actually a small catheter you have in your tummy, and it will automatically increase the flow or regulate your sugar level. And even better, now it will be connected to your watch or to a wristband, and it knows when you do this movement a few times, it knows you are eating, so it will infuse more insulin.
That's incredible. And that's amazing. Not yet in.
It is yet. It's already available.
Wow.
Already available in Mauritius. Is a pump. I can't say the name because we're not there to advertise.
No, that's fine.
But it's already available. It's an automated closed loop insulin pump. It's what's amazing? It's the patient is free of diabetes, because then he can. But it's mainly for type 1 diabetes, obviously. Sure. But again, the problem is if it breaks down. So then he still has to know how to inject himself insulin. But
then he doesn't have to inject himself. How many times did someone has to?
For type 1 diabetes, if you're on the basal bolus regime, you have to inject at least 4 times a day.
Wow, and that's harsh if you're a child, and I mean it could.
Yeah, and especially for children, it's very complicated. But sometimes you need half a unit. So parents are a bit lost. Say, how do I do half a unit?
Know? Yeah, or
how do I actually dilute even the insulin? So sometimes it's tricky, because I had a young child that she was 2, type 1 diabetic, and when she had 3 units of insulin, she would be in hypoglycemia. When she had 2, she would be high. So I told the mother, you have to do 2.5. So she looked at me and said, how do I do that? Yeah. So actually you have to dilute the insulin half. So you already pump the insulin, you add half of saline. I see. Okay. You try to mix it slowly, and then it's
so that's a game changer then for the.
It's a game changer. So it will completely change. And I remember one of my patients. She's an adolescent, so she gave me her pump. So I had to read up the mean glucose level. Mm-hmm. So I took the pump and I was like, I said, doctor, give me that. So she said, there's the mean. I said, thank you.
I do it every day. So.
It's like kids with the iPhone. They just know where to go. So no, I think the future is very interesting. And some of my colleagues, they don't like it when their patient go on Google or on ChatGPT. I love it. I do martial arts. I don't mind for a white belt to come and fight against me. I'm second dan in Taekwondo, so I'm fine. Come, let's have some fun. because
They're trying to educate themselves. As long as they don't go like me, they just, they go from A to Z, but, they're educating themselves.
But that's fine. Everyone with ChatGPT can become medical trained, but medium medical trained.
Sure.
Yeah. I have to be an expert in my field. So that will push me to always know more than you. And if I don't know, then I can still Google it up. So, and you can still research it, and you can actually then, obviously we don't use only Google, we use PubMed. So for people listening, we go on PubMed. So we will have to know our field more and more, and that's very exciting. That's why that's a new challenge. That's why my job is so amazing, because now with this ChatGPT, I will have pressure from the patient to become even better, and that's great. I think it's great.
Yeah. And also to kind of look at things a different way as well, because if you've been trained in one particular way and then the patient said, oh, I read up on this stuff about, I was telling you the other day, I haven't managed to stick to it, but I read that if you change the order in which you ate, it can help flatten your glucose curve, and I tried it a few times, and then
But it's interesting.
It's tricky when you go out to eat, but it's interesting because but it makes sense though, because it's the fiber first, and then the proteins and the fat, and then the starches and the sugars left.
Exactly, and that does work. And if we have many people doing that experiment, and if they send like on the social media, I did this, it did this to me, we will have like a data that is huge. We have to do medical trials to gather patients together that will do that particular stuff we asked them. Now we have that on social media. We have millions of people doing the same thing, so we will know this is good, this is not good. I think it's exciting.
I guess as long as it's not harming them as well, it can only help.
Hippocrates said that. Exactly. Primum non nocere. It means first, don't harm. I think it's very important. And he also said, make of your food your cure or your treatment. I think he's right. We should definitely listen to what the patient has to tell us. If he feels better, then we have to keep our mind open and think, well, maybe I was wrong and the patient was right. That's fine.
And how do you keep, or I guess you go to conferences, how do you keep up to date with, because we are a tiny island in the middle of nowhere?
Oh, that's the beauty about the internet. There's everything on the internet. Well, there's everything, and well, we have to go on serious sites. We do have updates with conferences. I go often to international conferences because it's important for me. Many people think that for me, my job is a passion. Now it's an obsession. It's worse. So I love reading medical articles. I had a lab coming to me this morning, and he was speaking about an antibody, and he said, do you know a lot about that antibody? And I said, I don't know enough. And I said, can you give me the reviews? And so he came back with a lot of papers, and I was like,
that he had read.
I was thrilled, because now I'm going to read up about that antibody, so I will know more about that antibody. And I think it has to be, you have to be amazed by your own job. And if it's amazing you always, that you discover new things, and so you keep updated. Yeah. I always say a doctor that is not keeping up to date, after 2 years he becomes useless, after 5 he becomes dangerous. So what I prescribed 5 years ago, I don't prescribe the same now, today. And even now, I just came back from an international conference about diabetes. One of the professors says that medicine shouldn't be prescribed anymore. And I stopped.
They probably still prescribe it here.
Yeah, it's very often prescribed, actually, even in hospital, unfortunately. But we don't have the choice, because we don't have
the
much
cost as well. Yeah.
Yeah, but I started to decrease my prescription of that drug 5 years ago, and since 2000, and no, even 7 years ago, because I diminished that prescription, and now I see that hardly any of my patients is on that drug. So it's good. Now he says he completely banished that drug from his unit in his hospital, but for some patients it's still necessary because they don't have the means to buy something more expensive. But you see, it's been only 7 years.
Yeah, and everything's changed. And I feel we'll see that as well in the field. We'll talk about that another time, antibiotics as well, because it's I remember, and I'll never forget that when I first came to Mauritius, I took one of my kids to a pediatrician. Very old guy. I don't know whether he's retired now, but I remember, and I'll never forget that he said a lot of pediatricians here overprescribe antibiotics. And I'm always fascinated by that, because obviously as a parent, and we'll finish on that note, as a parent, you're scared when your child has a fever. But actually, the fever means that the body is working to kill what it's, or to treat the, to kill the infection.
Who told you that?
I read about it.
I thought I did tell you
Or
that.
maybe you did, I don't know.
I always tell my patients that.
Because I always find it, if you go to the UK, obviously one of my children at least were born in the UK, and the NHS will only prescribe you antibiotics if after 5 days of fever, if it's not going down. But I feel that as a parent, obviously it's natural. We don't want our kids to be at 40 degrees or whatever, but in a way it's counterintuitive, because we're trying to bring it down, but by bringing it down, are we negating the effect of what the fever is trying to do?
Yeah, actually what I always tell my patient is fever is produced by your body. It's not produced by infection. It's actually your body
reacting to. Yeah.
Exactly. It will actually increase the thermostat so that the immune system can work better. So then you have more blood vessels or more blood coming to the infectious area, and your white blood cells can kill the disease.
Exactly.
And it's both ways. It's very complicated for parents to see their children having fever.
Yeah.
And sometimes they put a lot of pressure on the doctor, saying you have to prescribe me that antibiotic, and if you don't, I'm going to see another doctor that will prescribe me the antibiotic. It's a very complicated subject. I'll definitely have to come back.
Yes, I think so. We'll talk about that next
With
time.
pleasure. I'll come gladly again. No problem.
Thank you. And we'll talk about the other depressing topic I wanted to talk about, neurodegenerative diseases, and also associated with age, but not necessarily. I don't know whether it's on the increase in this modern age, but yeah.
It is. But choose also a joyful subject so we can laugh a bit.
In medicine, I'll try.
Not easy.
Thank you. Although I'm disappointed that you didn't give us as many quotes today as you did
Not
last
today,
time.
you see? I'll try next time.
Okay. Thank you.